I'm Dr. Marc Lubitz, and this is part 2 of my Grand Rounds presentation on elbow ulnar collateral ligament reconstruction. We'll be getting into the next part of the lecture here on epidemiology. Back in 2014, there was a popular news article that went somewhat viral saying that we had an epidemic of Tommy John surgery and UCL injuries spreading around the country. So let's break these figures down. In the United States, there are up to 5 million youth baseball players every year. 17% of all children play baseball. This gets a little bit smaller in high school, of around 500,000 high school baseball players, down to 45,000 in the NCAA. 3,000 pro baseball players, down to 750 MLB players. For youth baseball and high school baseball, there's no good centralized database that allows us to examine injury prevalence and incidence. For the NCAA, there was a database, and you'll see some published studies on this. However, it's now defunct. The Major League Baseball has the disabled list, which is publicly available and easy to do studies on, but incomplete and not designed for research. There is a specific MLB injury database that team physicians can access, and there are published studies using this. In Little League and youth baseball, UCL tears are exceedingly rare due to the open physis. However, elbow pain is extremely common. Up to 26% of youth baseball players have elbow pain at some point. In high school pitchers, there's a fast increase in the tear rate, and it's rapidly increasing year after year as well, presumed to be due to sports specialization and longer outings. This is a 2019 paper out of Brown and Dr. Brett Owens, looking at the epidemiology of UCL injuries in that NCAA database from 2009 to 2014. Over 5 seasons, they saw 109 total UCL injuries. 76% were contact injuries, compared to only 24% from throwing. Despite the lower number of throwing injuries compared to contact injuries in this study, the highest number of severe injuries, which they defined as missing more than 21 days of play, were higher in throwing injuries. While this is a useful study and helps to characterize the incidence and distribution of UCL injuries in college athletes, the overall percentage of throwing injuries in this study makes me think that the data set is incomplete. I would expect to see much more than 109 total UCL injuries over these 5 seasons in all college baseball players. Further prospective studies on college pitchers would be very helpful to better characterize this injury incidence. This study done at Curl and Jobe in 2015 was an online survey that was sent out to all 30 MLB baseball teams and to their athletic trainers, including at the minor league levels, who then distributed it to all their players. A total of 5,088 players responded, including 722 major leaguers and 4,300 minor leaguers. Of the respondents, 53% were pitchers. 10% of all players reported at least one UCL reconstruction. 16% of pitchers and 3% of others. And MLB pitchers, 25% reported history of a UCL reconstruction. This chart shows the number of UCL reconstructions done in MLB pitchers from 1974 up until 2014. You can see the obvious steep increase from the late 90s until the early 2010s. Interestingly, while rates have continued to rise in younger players, they seem to have topped out in MLB pitchers, at least over the past 5 years or so. We'll need to follow this trend into the future and hope to see it decrease in time. One of the most interesting features of this epidemiological data is the relatively low incidence of UCL injuries in Japanese baseball players. What's thought to be the biggest contributing factor is the 6-day rotation compared to the 5-day rotation here. This means that MLB teams have 5 starting pitchers that start a game every 5th day, compared to the extra day of rest that they get in Japanese baseball. There are multiple examples of Japanese professional baseball players, including Yu Darvish and Shohei Ohtani, who suffered UCL injuries and needed to undergo reconstruction once they made the transition from Japanese baseball to American baseball, and thus the 6-man rotation to the 5-man rotation. There's a yearly high school baseball tournament in Japan that is enormously popular, likened to March Madness here in the United States. Pitchers are known to have marathon outings, including a 15-inning, 250-pitch performance by Daisuke Matsuzaka in 1998. Further research on the incidence of UCL injuries and the effects of these outings would be very informative. We'll enter the next stage of our talk here with diagnosis. In a throwing athlete with elbow pain, UCL injury is always on the differential. Patients can present acutely with chronic elbow pain or with an acute change in chronic elbow pain. Pitchers presenting with an acute injury can sometimes recall an exact pitch where they felt a pop. This chart is showing data from our cohort in Cincinnati of 163 pitchers presenting with UCL reconstruction. You can see here about 38% presented with chronic elbow pain only, 45% had an acute injury with no previous elbow pain, and 17% had previous elbow pain with then an acute pop. It is thought that in throwing athletes, any acute injury is still the result of chronic attrition, whether or not they had elbow pain previously or not. With a throwing athlete with elbow pain, the differential diagnosis is going to include medial epicondylitis, ulnar nerve irritation, a flexor pronator mass strain, and an olecranon stress fracture. If the patient has open physes, you have to consider an avulsion fracture or apophysitis as well. It's also important to distinguish patients who have lateral or posterior elbow pain, which would result from a totally different etiology. Now on to physical exam. So all physical exams on any part of the body should begin with inspection. It's normal to see ecchymosis around the medial part of the elbow about 1 to 3 days after an acute injury. You want to palpate the UCL with the elbow at 50 degrees of flexion. This helps to move the flexor pronator mass anteriorly and out of the way. Pain to palpation is around 90% sensitive, but only 20% specific for a UCL injury. You want to rule out a flexor pronator mass injury by looking for pain with resisted wrist flexion and pronation. Next, you want to examine for ulnar nerve symptoms. Palpation will cause pain if there's ulnar neuritis present. You want to check for subluxation with the flexion extension arc as well. The images on the slides show the two most specific tests for UCL injury. On the left is the valgus stress test. Here you want to flex the elbow to 30 degrees, stabilize the humerus, and apply a valgus force. Laxity is subtle and often only around 2 millimeters, so you must compare to the other side. It will be painful as well in an acute injury. You can use fluoroscopy to help more accurately compare between the two. This test is noted to be 66% sensitive and 60% specific. The image on the right shows the milking maneuver. In the milking maneuver, the forearm is supinated fully and the elbow is flexed beyond 90 degrees. The thumb is then pulled laterally by the athlete's contralateral extremity or the examiner's hand. This creates a valgus force on the elbow. Pain, instability, widening, or apprehension is indicative of injury to the UCL. This is a third important physical exam test called the moving valgus stress test. For this test, you're essentially trying to replicate the throwing motion. You abduct and externally rotate the shoulder, and the arm is flexed and extended with a valgus force on the elbow. If done initially, the test is reported to have a 100% specificity for UCL injury, but it decreases if the patient hasn't thrown in a while. Ultimately, before any UCL surgery on a pitcher, you're going to need imaging to correlate your physical exam findings with. This study looked at literature from 1947 up until 2019, comparing stress radiographs, ultrasound, MRI, MRA, and CT scan. They found over 2,400 articles, but included 15 in the study. They concluded that MR arthrogram is the most sensitive and specific, but that more research comparing ultrasound and MRA is needed, as ultrasound has some promising aspects. Again, a common orthopedic theme here is that we're going to start with x-rays. You'll get an AP, a lateral, and an olecranon view, looking for olecranon stress fractures. With tensile stresses medially, there is a compressive force laterally between the radial head and the capitellum and the olecranon into the olecranon fossa. This can cause osteophyte and loose body formation that can also be seen on x-ray. This is part of an injury spectrum called valgus extension overload that is related to UCL injury. You can see here on these x-rays that demonstrate posterior medial olecranon osteophytes and calcification of the UCL. This is showing a valgus stress x-ray, comparing the affected side on the right to the unaffected side on the left. You can see slightly increased widening there, though it is somewhat subtle. The x-ray on the left here is showing a avulsion fracture of the distal insertion of the ligament. The x-ray on the right is showing an avulsion fracture of the proximal insertion of the ligament. This is an image of an MR arthrogram showing a full thickness distal tear. You can see the contrast extravasating distally where the intact ligament should be stopping it. This image is showing a full thickness tear proximally. Here you're seeing an MRA showing what's called a T sign, which is a partial thickness undersided tear. This MRA is showing diffuse thickening with some ossification of the UCL in a chronically injured patient. This is a 2014 study by Dr. Cicciotti out of Rothman looking at ultrasound to diagnose UCL injury. It was a cadaver study where they sequentially sectioned parts of the ligament complex and measured how much gapping occurred. Ultrasound is an emerging tool for UCL diagnosis and is valuable, especially in that it's a dynamic test which can measure gapping under valgus stress. Ultrasound, especially dynamic ultrasound, is a very valuable adjunct and potentially better than MRA by some studies, but does have the downside of possibly missing articular-sided partial tears. This is a great review study by Dr. Cicciotti out of Rothman looking at UCL evaluation and diagnosis. Essentially, you start with history, looking at symptoms that are maximized in late cocking and early acceleration, clarifying between an insidious and acute onset. On exam, you look for tenderness directly over the UCL, along with your more specific tests, the milking test and the moving valgus stress test. And then you finish your diagnosis with imaging studies, including MRI and possible dynamic stress ultrasound.